Hi, everyone. Just welcoming you to our What's New in Pharmacy. Today we have Turner, and I'll introduce Turner. Turner is a Métis pharmacist from Vancouver Island. He has a background in community pharmacy and now works with a First Nations health authority as a health benefits and services pharmacist. He's one of 2 addiction pharmacy fellows with a BC Centre on Substance Use for the cohort of 2023 and 2024. So I'm going to welcome Turner here, and he's going to talk about the impacts of psilocybin on substance use disorders.
Thanks, Mona. Hello, everybody. As mentioned, my name is Turner. I'm a pharmacist. I graduated with my PharmD in 2021 from UBC, and as mentioned, I'll be talking about the impacts of psilocybin on substance use disorders. So before we get started, I wanted to acknowledge that we're gathering here today on the unceded lands of the Coast Salish people, in particular the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I took this photo here just last weekend, actually, and just took some time to reflect on how grateful I am to live here and to work here, and especially to play here on these lands that have been stewarded by Indigenous folks since long before colonization, and encourage folks in this room and on the call to do the same and continue to reflect on an ongoing basis when you're out recreating on the lands. So kind of went over this already, but here are my disclosures. Nearing the end of the Addiction Pharmacy Fellowship with BCCSU. I'm funded by a SUOP grant for that. I also hold a permanent full-time role as a pharmacist on FNHA's Health Benefits and Services team, and I have no relationships of any sort with commercial entities. Here's the outline. So I'll briefly go over the history of psychedelic research, talk a bit about psilocybin pharmacology, discuss how we can honor Indigenous principles in psychedelic research and practice, and then do a high-level overview of published Western research in this space, and then some considerations for practice and future research. So the learning objectives, hopefully we'll gain an understanding of the history of psychedelic research and psilocybin pharmacology, recognize the need for meaningful engagement with Indigenous communities and inclusion of their perspectives in psychedelic research and treatment development. And we will lastly review published Western research on the role of psilocybin and psilocybin-assisted psychotherapy in substance use care. So I just wanted to start off with some general information on psychedelics as a primer. They're loosely defined as psychoactive substances that powerfully alter perception, mood, and a host of cognitive processes. Some are synthetic, but others can be found in plant and fungi, with many of the organic psychedelics being harvested and taken by Indigenous folks as part of broader spiritual practices for millennia. In fact, the term psychedelic itself is more of a Western term. Indigenous communities may instead refer to them as spirit medicines, or simply traditional medicines, or other terms. So psilocybin itself is a naturally occurring prodrug. It's found in over 200 species of fungi. After oral ingestion, it is dephosphorylated by alkaline phosphatase to the active metabolite psilocin. You can see both of those compounds on there with a varying R group after metabolism to psilocin. Psilocin is a tryptamine-like compound and is a selective 5-HT2A agonist. And the activation of this serotonergic receptor is thought to be the driver of the compound's psychedelic properties. And of note, psilocybin isn't necessarily thought to have any sort of addictive properties itself. This has been postulated to be due to the fact that they don't work on the dopamine system.
Is that true of any kind of psychedelic or any drug like that?
I'd have to. Yeah, I think in general, like less addictive properties. I mean, some.
I do that stuff every day.
Yeah.
Sorry.
No, that's okay. There are some drugs that have some psychedelic properties, like ketamine, for example, that you can see addiction from. However, it's certainly less prevalent.
But it works as a potent.
Yeah, it's on the NMDA receptor.
Yeah, it's dissociative.
Yes.
I think it's more the dissociative aspect than it is the psychedelic aspect of the ketamine. Although we could talk about probably at another time.
No, okay. Don't mind any questions at all.
Local natives, First Nation groups using psilocybin, or is it like South America, North America wide, or is it certain groups?
So you see it like worldwide, actually. I'm not certain about like the specific regional communities here in BC in terms of like how much uptake there is of different spiritual practices. It's something that's often held sacred by the communities. However, I'm going to get to a study that talks a bit about some of the principles of honoring Indigenous, and no worries, and I think it'll go over it there. And it kind of discusses the worldwide use. So yeah, that serotonergic agonism is really what's thought to be the primary driver for psychological effects. And quickly, just kind of going over some of the pharmacokinetic properties of psilocybin. The onset of action is typically about a half an hour. The peak effect coincides with the peak concentration of psilocin, and that's roughly about an hour after onset. And then the total duration of effect is about 4 to 6 hours. This table I pulled from a study. It used a dose of 0.25 milligrams per kilogram of psilocybin, which is actually close or similar to what we see in the clinical trials I'll discuss later on. One thing that's important to note dose-wise is this is the dose of pure psilocybin. It's not the dose of the magic mushrooms themselves. Mushrooms are typically about 1% psilocybin, but this varies from strain to strain with other factors. And then also to note too that this PK or pharmacokinetic data is from a study that doesn't necessarily have the same level of rigidity that be required for trials that lead to Health Canada approval of a drug product. So I suppose take it with a grain of salt, and also just recognize that pharmacokinetics likely vary from person to person and on factors like food consumption and otherwise. So kind of moving on into a little bit of the history of psychedelics, in particular Western psychedelic research. There was some recorded Western use of psychedelics in the late 1800s and perhaps even in the 1700s. However, the larger influx of research began sometime around when Albert Hofmann synthesized LSD for the first time in 1938 and took his famous bike ride through Switzerland. Afterwards, recreational use of psychedelics quickly became popular with widespread use by the 1970s in America. And this actually was kind of part of a counterculture, some would say, which led to government controls being placed on psychedelics in the late 1960s and early 70s, which really unfortunately effectively halted research on psychedelics for the time being. However, there's been a sort of resurgence of psychedelic research, many of these studies having quite positive results. And now we have a better understanding that the intensified feelings of existential and spiritual well-being that is often reported by psilocybin users is really kind of the core of what can make these compounds effective for treatments in fields like substance use or psychiatric care, or palliative care even. In fact, MDMA, psilocybin, and ketamine have been designated as breakthrough therapies for psychiatric conditions in the US and in Canada. There's many ongoing clinical trials, but we actually have access to psilocybin and MDMA through the special access program here, along with the CDSA exemptions to help with like transport possession. And like I said, there's many kind of ongoing studies, and they're looking at different psychedelics for a variety of conditions, substance use and others, and they're kind of lots up and coming and to be published soon. So in preparing for this presentation, I knew I had to talk a bit about Indigenous perspective on psychedelics or spirit medicines, given that these are often plant medicines, and many have been used by Indigenous folks from across the world long before the Western knowledge of them. For personal reflection on my work with FNHA, as well as the conversations I've had with communities, with elders, traditional medicine keepers, I have a bit of an idea of the concerns for many Indigenous nations surrounding the lack of recognition of positioning of these medicines as sacred, as well as the sort of exclusionary practices in Western research and clinical practice, and the general lack of inclusion of Indigenous voices in this space. Despite a great deal of Indigenous knowledge on these powerful medicines, the field is currently widely represented by Western folks. And so I decided to dig into this a bit deeper, and I actually found this excellent article. It's written by an Indigenous-led group, and it was published in The Lancet in 2023. The Indigenous group consisted, I believe, of 8 people from across the world, 1 person from Canada and from other areas in the world. They got together with the purpose of formulating a set of ethical guidelines concerning traditional Indigenous medicine use in Western psychedelic research and practice. And they used an adapted consensus development panel, which platforms and centers Indigenous ways of knowing and knowledge gathering and sharing. And the end result was the 8 principles you see here. They're broken down into 4 categories, each of which I will touch on in brief and share some of the discussion that was included in the paper. So the first two principles are related to acknowledgement. So there's a need for the direct acknowledgement of Indigenous traditional knowledges and practices being the root of Western psychedelic medicine. And the first principle is reverence, and really that's a deep respect for the fact that traditional Indigenous medicine is an ethical, ecosystem protective, and holistic system of medicine that interconnects humans and the environment. This sense of reverence for the planet should guide all relationships, as well as a commitment to preserve all life. And the second is respect. And really, it's just about having a respectful approach to engaging with Indigenous people and their ways of knowing and being. And that's really urgently needed within our Western field of psychedelic research. And this kind of consists of approaching Indigenous knowledge systems through relationship building first and foremost, and meeting with Indigenous scholars and practitioners, organizations, and respected traditional knowledge keepers within regional contexts. And upholding free, prior, and informed consent during engagement and prior to utilizing traditional knowledge in new ways is required. Simply put, nothing about us without us. So the next two principles relate to knowledge translation and education. So there's a need for culturally appropriate and accurate translation of Indigenous knowledges within Western psychedelic research and practices at institutional and civil society levels. So there's a responsibility for the institutions that lead, host, or enable this type of research to be accountable for the promotion or engagement with any cultural appropriation, for any capitalization off of Indigenous people and their cultural practices without their free and prior and informed consent, and for enabling directly or indirectly white supremacist legacies in psychedelic research, training, and practice. So really, there's kind of a need to own up to the fact that a lot of this has been happening. And also responsibility for inclusive and respectful practice moving forward. The second within this knowledge translation and education realm is relevance, and just really kind of acknowledging the fact that Indigenous people and their traditional knowledge are relevant and needed within our Western educational systems, research, and practice. And we really should take big steps to elevate their leadership and presence. Really, so, they have many, many years of utilizing these types of medicines and a great deal of expertise and knowledge and wisdom and how they work. And so we should really be tapping into those and doing so respectfully and with reciprocity. And also by just making sure that these spaces are culturally safe, both in terms of like learning, education, research, practice, and so on. The third set of principles is related to IP or intellectual property. So really, the first principle is regulation. So really just kind of crucial to continue the generation of constitutional recognition with specific clauses on the protection of the IP of traditional Indigenous medicines and practice and their use and development, both at the national and international level. And then there's reparation. So Indigenous peoples do have the right to maintain, control, protect, and develop their own knowledge, medicines, and cultures. And they should receive fair and equitable sharing of benefits derived from the use of any natural and intangible intellectual, cultural, and spiritual heritage as they see fit, which could even include post facto reparation in instances where Indigenous knowledge was used without free, prior, and informed consent, or essentially was stolen from their communities. The final two principles relate to belonging, and really they are achieved by combining elements of the first six principles. The first is restoration of Indigenous authority. So essentially restoring Indigenous knowledge, context, and practices as the guiding voices in the development of tangible and intangible traditional Indigenous medicines and practices. And reconciliation of Indigenous Western relations. So working with Indigenous peoples and their traditional systems, and involving local, national, and international levels of cooperation with government and non-government organizations to establish restorative, transitional, and transformative justice procedures. And in summary, I mean, these principles can be useful when considering how to move forward with psychedelic research, product development, and clinical practice in a good way. It's just one article. However, I think it's the first of its kind from what I could find. But I do think it's important to note that these principles were developed based on the voices of the participants' respective communities and may or may not be generalizable to the beliefs of all Indigenous communities. That said, the consensus group that wrote the paper did comment on this as well. They noted their confidence that the general elements are applicable or relevant to many Indigenous nations. However, there could also be missing elements or some elements that should be included depending on the context. So really, it's important for those working in this field, so people in the room today, people on the call, if you're working in psychedelics, to really ensure engagement with respective surrounding regional Indigenous communities and organizations. And I do want to acknowledge that there is a lot of this good work happening here in BC, and folks in the local area should consider looking into what existing organizations are out there and consider engaging with these groups as well. So with all that in mind, I'm just going to shift gears back to Western science to review some of the published research on the impacts of psilocybin on substance use disorders. I only really reviewed the observational studies that had results on the impacts of psilocybin use on their own, rather than looking at like a pool of psychedelics and the association on the different outcomes. And similarly, only will look at interventional studies that use psilocybin as a sole psychedelic for psychedelic-assisted psychotherapy. So we're going to start with the observational studies. These are all retrospective observational studies analyzing the data of respondents aged 18 or older to the 2015 to 2019 U.S. National Survey on Drug Use and Health. The survey examines health outcomes and substance use within a nationally represented sample of the U.S. I somewhat disagree with that. It does exclude those experiencing homelessness, active duty military members, and incarcerated individuals. So that's something really important to keep in mind. And of course, while researchers did attempt to control for variables afterwards, such as educational attainment, household income, age, the best we can ascertain is associations from these types of studies. And the number of people analyzed in each study was 214,505. So the first study was a retrospective observational study. It analyzed whether lifetime use of each of the classic psychedelics had an impact on odds of past year opioid use disorder diagnosis. And it was actually shown that lifetime use of psilocybin, so any instance of psilocybin, just yes or no, in those that had yes, there was actually a lower odds ratio or odds risk of having opioid use disorder, the adjusted odds ratio of 0.7. And there was actually additional sensitivity analysis done that showed psilocybin also was associated with significantly lower odds of 7 of the 11 DSM-4 criteria at the time of the study. Interestingly, none of the other classic psychedelics were associated with a lower odds of opioid use disorder in the study. And I think the definition of a classic psychedelic included psilocybin, peyote, mescaline, and LSD. Again, it's a very similar study. It's the same primary investigator, and it analyzed the same data set, except it analyzed whether or not lifetime use, any single episode of a classic psychedelic was associated with odds or changed odds of current nicotine dependence. So the last was past year opioid use disorder. This is of current nicotine dependence. And yes, there were slightly lower odds of current nicotine dependence as measured by 2 different scales. So the nicotine dependence syndrome scale and Fagerstrom test for nicotine dependence. The odds ratios are there around 0.9. And statistically
I
significant.
think they're fishing. You got 200,000 people. You're like, what's popping up in terms of that social media data? I mean,
Yeah.
I'm sorry, who cares? I mean, like, is anybody actually going through recovery in this moment? Like, I'm just saying, like, I could do this stuff, and I don't think it adds anything to the scientific community. And I'm sorry if that is directed to you. I'm just saying, is this useful for anything?
No, I actually tend to agree. I think, being an observational study, especially with like some of the variables and the exclusions that they had in the studies, it's, I think you really kind of have to take these with a grain of salt. I thought it was just interesting more than anything. I don't think
It's
it's
that big of a number, with that big of an end, man, you're gonna get things dropping up, associating, and, I feel like I've worked with Vitus and some data from Vitus Access, HIV, injection drug user stuff. I know we got a pretty good data set there, and during my study, if you fish enough, you're gonna come up with something that's sort of like I looked at HIV and cannabis use and adherence. But anyway, I'm critical of that piece about the research, and it could do better than that, I hope, but maybe the other stuff's better.
no, I do tend to agree, to be honest. I don't think it's something
I
that's
had an anecdotal experience when I was working at Vitus one time, where somebody said that they did acid, they did an LSD trip, and they had this night of walking around, and they stopped using it. It was 8 months. She said, I haven't used it in 8 months. I never heard anything. I thought, bullshit. Absolutely, must be, but why would you make that up in an interview setting where there was no reason for her to tell me that? You know, that was what I found was, although arguably you could say that you're not using substances when you are, and it makes you look better to me, which it certainly did. But I'm looking for stuff like that where people are actually having a change they're experiencing.
Yeah. So I think the comment for those that are online, just essentially, no, it's okay. Essentially kind of considering like, what does this data actually mean? Is it meaningful at all? And I think the point was that perhaps, you know, with such a large data set, if you're analyzing so many different outcomes, eventually you're going to come across something. And I think it's a very valid point, especially again, when we exclude people with homelessness and with other factors that may actually have a heightened risk or prevalence of substance use disorders. So you certainly have to take it with a grain of salt. Interestingly, some of these like found that certain psychedelics had benefit and others didn't when you looked at the adjusted odds ratio. So I just thought it was more interesting than anything.
Down into the data, you actually look more interesting.
Yeah, when you look at the kind of like you break the classic group of classic psychedelics down into smaller groups or individual compounds and looking at the associations there, they were different outcomes. So it's hard to you know say any causality from an observational study, of course, but or impossible, but it's still interesting, I thought. And so allow me to just share this last observational study. Again, similar study using the same data set. This analysis looked at whether lifetime use of a classic psychedelic had an impact on odds of, again, past year cocaine use disorder. And in this case, lifetime use of psilocybin did not have a statistically significant effect on this outcome. So again, take the data with a grain of salt, but there is some variance depending on the type of substance you're looking at.
So for people that are using actively for the span of their lifetime, they're not using cocaine in a way that indicates the use disorder.
Well, no, so for people that had used one instance of a classic psychedelic in this presentation, specifically looking at one instance of psilocybin, they had no difference, or there was no statistically significant difference in the prevalence of past year cocaine use disorder.
So it didn't have an impact.
Yeah.
Thank you.
No problem.
It's hard to.
No problem. And so these are, I would say, the more interesting and kind of relevant studies to practice. These are the 3 interventional studies, which use psilocybin as a sole psychedelic as part of a psychedelic-assisted psychotherapy program or regimen. Before I jump into the studies, I wanted to say just a quick note on what psilocybin-assisted psychotherapy is. So psychedelic-assisted psychotherapy involves the use of psychedelic substances as an adjunct to psychotherapy for facilitating therapeutic breakthroughs and insights. So for example, using MDMA assisted psychotherapy, ketamine assisted psychotherapy, psilocybin assisted psychotherapy to allow people to, I guess, open up a bit more during their therapy sessions. The number of sessions that take place varies from one study to another. Typically, there'll be like some preparatory sessions without the use of the psychedelic, and then they might do a session where they do administer the psychedelic during the psychotherapy, and then some sessions without the psychedelic, and then 1 or 2 more sessions with the psychedelic. And I'll describe that for each individual study. Typically, it involves 1 or 2 psychotherapists and generally takes place in a comfortable room. Usually has like some different kinds of art and objects as well as music. Patients can lie down, they might have a blanket or eye shades. So like comfortable environment typically. So this first study, well, I guess I'll say for each of these, the slides are pretty busy, so I'll try to walk you through them, going from left to right. First, looking at the patient group, then the intervention, then the control if applicable, and finally the outcomes. And again, just keep in mind, this is a pretty high level overview of each study. There's a lot more nuances and even other outcomes that I haven't included here. I just looked at the primary outcome for each, but perhaps someone on the call can make one of these your next journal club article if you really want to dive into it. The first study here by Bogenschutz is a single arm, very small clinical trial, enrolled 10 patients, a mix of males and females. The average age was 40. The patients had to have a diagnosis of active alcohol dependence per DSM-4 criteria, and the mean duration of alcohol use disorder was 15 years. And they had to also have at least 2 heavy drinking days in the last month. There had to be concerns about their drinking, but not currently in treatment or using any treatment medications. And there was also fairly broad exclusion criteria. So couldn't have any, essentially any psychiatric conditions, no psychostimulant or opioid dependence, and no family history of BPD, suicide, or schizophrenia. The intervention was 12 psychosocial intervention sessions. So there were 7 sessions of motivational enhancement therapy, 3 preparatory sessions, and 2 debrief sessions. So essentially they had a few preparatory sessions, and they did 1 motivational enhancement therapy session, and then they did another motivational enhancement therapy session at week 4. And that was including psilocybin, 21 milligrams per 70 kilogram at that week 4 session. And then they had a few more sessions the next following weeks without any psychedelic, and then a second psychedelic assisted psychotherapy session at week 8. And this is with an increased dose. So 33% increase, so 28 milligrams per 70 kilograms. There was no control. It's a single arm study. However, there was a statistically significant reduction in percentage heavy drinking days versus during the week 5 to week 12 post regimen follow-up versus baseline. So there's a mean difference of 26% heavy drinking days. These improvements were actually maintained versus baseline at week 36 follow-up. And there was actually no reduction that occurred in the weeks 1 to 4 before there was a psilocybin-assisted session. And this is a pilot trial, and it actually led to what I would think is probably the most interesting clinical trial that I've included in the presentation.
Where's it located geographically?
I believe it's in the US, 2 centers. It's actually done, I believe, at a university. The participants were recruited via newspaper, interestingly.
Just somewhere in the south of the US, yeah?
Yeah, I think it's southeast, if I remember correctly, but I'd have to double check to be certain. I can let you know afterwards. So this was actually an RCT, randomized controlled trial. The patient group included 95 individuals, slightly more males than females. The mean age is a bit older, 45, around 45 or 46, and they were assigned randomly 1-to-1 to receive the intervention or control, which I'll highlight in a minute. Again, pretty similar kind of inclusion criteria and exclusion criteria. They had to have an active diagnosis of alcohol dependence. The mean duration for the participants was 14.8 years of an alcohol use disorder, and at least 4 heavy drinking days in the last month. So that's a little bit higher than the last study. There had to be concerns about their drinking, but not currently in treatment or on treatment meds. And again, pretty broad exclusion criteria, the same as the last or the initial pilot study. So in this case, it's quite similar in the makeup of the intervention, in that it's 12 psychosocial intervention sessions one per week. This time they used motivational enhancement as well as CBT, and there was also some resources to help participants manage and make use of the psychoactive effects of the study and medication. I couldn't actually find those in the appendix. I was curious what that actually entailed, but yeah, there was some more details though on like the training, the supervision, and also the fidelity monitoring procedures described in the protocol and the supplement. So if interested, you can take a look at that. But essentially, these people were again given 25 milligrams per 70 kilogram at the week 4 session of psilocybin, and then 25 to 40 milligrams per 70 kilogram at the week 8 session of psychotherapy. And the dose increase was essentially based on the tolerance and whether or not people felt like they had an adequate spiritual experience. So if they felt like they could tolerate more, didn't have any serious adverse events, then they could go up to the higher dose. And then the control was the same psychotherapy, but instead of getting psilocybin, they got diphenhydramine. So 50 milligrams at week 4, and then 50 to 100 milligrams at week 8. There wasn't really a strong justification as to why they used diphenhydramine, but if, as a pharmacist, I'd probably speculate just because of some of the sedating effects, perhaps like, yeah, it's cheap.
In terms of side effects, right?
Yeah, it has like some of that anticholinergic effect, make people feel like a little bit altered, perhaps. Yeah. So that was my hypothesis.
If you do enough gravel, you're gonna feel like you've had something in you that you shouldn't have yet.
Yeah, for sure. I don't know like how much. I guess.
Same probably.
Yeah. Yeah, I think it's.
Seen somebody walking when I was a teenager, somebody like 12 gravel. He was like totally walking sideways. Very odd behavior for somebody who would take a lot of gravel.
Yeah, I've heard of
recreationally or whatever. Yeah, I was quite never seen anything like it.
It's kind of that anticholinergic toxidrome, I think, that we see. Yeah. Yeah, it's actually, I think it can be unsafe, but we can have like ECG changes and everything. But anyways, for the outcomes, we looked at, or they looked at the percentage of heavy drinking days during the 32-week double-blind period versus control. And there was a a statistically significant reduction. So there was 9.7% percentage of heavy drinking days versus 23.6 for the diphenhydramine group, which is a mean difference of 13.9%. So that's a difference in like how the percentage after treatment. The baseline was actually higher for the psilocybin group as well. So they didn't compare to baseline, but they just compared them head to head that way.
Were they worried that they would be blind once they took it? Like they know, okay, I'm in the control, like
Yeah,
are you worried about that?
I think,
And
yeah.
my worry is that you can't really blind somebody at the fact they're not getting.
It was acknowledged during the study, the fact that it's difficult to, or in the discussion, it's difficult to blind somebody, especially if you're going up to these higher doses, like 40 milligram per 70 kilogram is a fairly high dose. So
And are they all naive to psilocybin when they begin the study? Is all the people have never taken any kind of hallucinogenic before?
I'd have to double check, but I believe the criteria was they couldn't have used a psychedelic in the past year.
But not necessarily naive.
Yeah, not necessarily completely
Okay.
naive in their lifetime. Yeah, for sure.
But not know the difference between gravel and mushrooms, but if you had taken them before, you probably know.
Yeah, and I suppose it depends if people have taken gravel too and know how it
I
affects them,
suppose.
right? Yeah. In this study, mean daily alcohol consumption, so just the number of standard drinks per day, was also lower in the psilocybin group. So 2 positive outcomes from this RCT. The last
Any lasting benefit from the group, like in terms of they did 3 and 12, I think, weeks, is that right?
So they did 32 weeks, and then I'd have to double check, but I believe there was a year follow-up and the benefits were maintained
There
too.
were some benefits, okay.
Yeah, I'd have to double check though, so don't quote me on that. But last study is a clinical trial by Johnson et al. Again, single-arm study. This one was looking at the impacts of psilocybin on cigarette smoking. A small trial, again, 15 people, 5 females, 10 males. Mean age was 51, so a little bit older in the study. Patients had to be smoking at least 10 cigarettes per day with an average of about a pack per day, with a duration of average of 31 years of smoking. They had to have multiple unsuccessful past quit attempts and the desire to quit smoking. And they also had to be healthy as determined via medical interview, ECG, blood, and urinalysis laboratory tests. And again, like some other exclusionary criteria, so no personal or family history of psychotic or bipolar disorders, and no active drug dependence, including alcohol, and of course, excluding nicotine within the past 5 years. So participants received weekly cognitive behavioral therapy for smoking cessation from a doctor level psychologist for 15 weeks. And then at the week 5 session, they got psilocybin 20 milligrams per 70 kilogram. And then at the week 7 session, they had 20 or 30 milligrams per 70 kilogram. And optionally at the week 13 session, they could also do another round of the same dose they had in the week 7 session. There was no control, unfortunately. And the outcomes, but once again, it is hard to control for this type of study, but the outcomes, they did show that 12 out of the 15 participants had biochemically confirmed abstinence at the 6-month follow-up. That's pretty strong outcome, I would say, considering I think the standard of care is less than 35% abstinence when we're treating a nicotine use disorder. And 11 of these 12 actually reported a cessation after just the first psilocybin administration. This is like a pilot trial, and there was an extension looking at long-term follow-up. So at 12 months or longer, 9 out of the 11 who presented for that long-term follow-up, who were included out of the 12 of the 15, had sustained abstinence. So I would say, pretty impressive results, but of course, such a small study, so it's hard to say if this is adequately powered or not. But one also other thing interesting here is that people found that they correlated what they defined as the mythical experience that people have with psychedelics to be essentially be more effective in reducing the risks of, or I guess improving the outcome of the study. So people that had more of a trip were correlated to have better outcomes for their substance use disorder, which is interesting. And that was actually similar to the other 2 studies as well. So my last slide here with some considerations for research and practice. While the results from these early studies are promising, psilocybin and psilocybin-assisted psychotherapy are still fairly inaccessible. There are some programs that exist out there for this type of psychotherapy here in BC, but from my understanding, it's all private. It's quite expensive. I don't believe there's any solid programming for substance use disorder treatment in particular. Correct me if I'm wrong, but the good news is there are many ongoing randomized control trials, again, exploring the use of psychedelics for various substance use disorders and other conditions. And that'll be helpful to support increased public access to these types of therapies if the evidence continues to be positive. So as a clinician, just continue to monitor. If you're involved or interested in research, get involved with it and keep an eye out for the availability of these services for your clients. In particular, I think for the ones that perhaps have failed on other treatments. I know that last study looked at people with multiple unsuccessful quit attempts, and it was fairly effective. So I think it could be a good kind of later line in treatment. And
What we have is working now, you know, I mean, what do we got to lose with the current treatment, right?
Yeah.
I mean, we have the current model and medications within that are okay, but why aren't they trying to bring in more stuff? It's always the question.
yeah, I believe I totally understand. And the
There's
comment
some
was,
benefit, you know, and you might be missing people that, you know, don't respond to conventional medication, et cetera, right?
yeah, the comment is why not? Why aren't we bringing these in earlier? And I
The highest rates, I mean, our rates of alcohol, into the hospital, the cost of alcohol in the hospital, like surpassed cardiovascular illness.
yeah,
Like 3 or 4 years ago, I mean, we need to start treating alcohol. I think
absolutely.
alcohol use is right.
Yeah, so I think, I mean, even just kind of basing off that one, probably the best published study for looking at psychedelics for substance use disorder there is a good platform to base that sort of rationale off of, I would say. And one thing I didn't comment on too, which I'll just quickly note too, is the safety. I didn't include this in the studies or at least in the on the slides, but generally pretty well tolerated. There wasn't a whole lot of side effects.
Thank you.
No, I don't. No, I don't think there's ever been a documented.
Ketamine, you probably could. You could,
Yeah.
respiratory depress.
Yeah, I think you
Like
can.
speed or-
There was some, I don't think there's ever been like a documented fatal overdose on psilocybin itself on its own.
Right.
Um,
You
but
could have psychotic breaks.
yeah.
Yeah.
A few of the studies did demonstrate some like changes in blood pressure as well, increases in blood pressure, but I don't think in the one study that actually had medications on hand, they never felt the need to actually use that in the participants. So perhaps some like hemodynamic changes in terms of safety. However, nothing warranting treatment. And I just want to finish off just by noting that we can't forget to consider how we can respect the fact that these medicines were known long before we knew about them as Westerners. And so in taking steps towards truth and reconciliation here in Canada, we should question how traditional Indigenous knowledge, cultural rights, and opportunities for economic participation will be adequately protected as psychedelics gain prominence here in Canada. And the references are there. And if you'd like to do the survey, it'd be appreciated. And I think
Yeah.
questions.
Thanks, Turner. There were a few questions in the audience, and then I'll just take a look here as well. Lots of considerations, lots of thinking to do. So there's one question from the online, is why are the majority of these studies, if not all, from the USA? Number one, and for you, Turner, do you foresee more Canadian studies on the way due to the special access that you had mentioned here, or why is there such a lack of information thus so far?
Yeah, so I think the majority of the studies being in the US and the lack in Canada is because the special access program was just granted their first approval, I think just a few years ago. So there's kind of I guess, a lack of evidence thus far to publish anything on it. However, I do know there is some ongoing research here in Canada being done right now. And so I think we will see kind of an increase in publications over the next few years and hopefully continue to see promising results.
Yeah, go ahead.
Yeah, I just wondering, like, we had mostly the trying to think of the name of the word, it's not scientific data, help me out here.
Observational?
Observational and those small study groups, but it's as science as you can get statistically, etc. I'm trying to think of the example, the type of research where you get 10 people and you all ask them about phenomenology and, sorry guys, I'm brain gapping this time, but the other type of evidence that isn't all science-based.
Qualitative?
Qualitative, thank you.
Yes.
Is there qualitative evidence that suggests benefit? And I think, haven't they been studying this stuff through UBC and SFU through their, don't they have an arm of their research thing that's been looking at alternative medication for over 10 years? I feel like since I did my master's a number of years ago, they've been churning out at least the qualitative data piece. Am I wrong?
So the question is for the online is, how much qualitative studies are there out there and what are the opportunities, I guess?
Yeah, I think there's a lot of opportunity for taking a look at this. There is actually some qualitative data within the studies I looked at here, like in the trials. There was like some subjective findings from the participants, for example. I'm not certain of like any qualitative publications from here or from BC that have been published to my knowledge, but I wouldn't be surprised if there are things out there that
There's an
that were
actual
here.
name for it. I can't remember it, but there's like a coined term where they, alternative psychedelic substances, MAPS or something like that.
Yeah,
It's a
MAPS is
multi-study site, is it, I think MAPS?
yeah, MAPS is I think the one that you're referring
Have they
to.
published anything around for a long time? I feel like they must have come up with some good data by now, or?
Yeah, I think there is a lot
I
of
should just say data, because I tend to be a little bit on the quantitative side of things and overvalue quantitative research. That's my perspective, but I know the qualitative stuff is there. And sometimes in cases like this, can be more easy to track the benefit.
yeah, certainly, and I think there is a great deal of other evidence being produced by groups like MAPS, just not necessarily applicable to this presentation, but it is important research still. I think it's more just focused on psychiatric conditions. Like, so for example, like we have there are products like on label here in Canada that can be used for psychiatric conditions.
The other forms of,
Yeah, so just not necessarily included for substance use disorder treatment, but certainly lots of other
It's that, sorry, I get it now.
yeah, no worries.
You gotta pick it up a little bit.
Yeah.
We're gonna-
Yeah, that's a good question though. Thanks.
Are there any further questions? Yeah, a question from the audience here.
Review and certainly an emerging area of something to care. I just had a question about like the emerging studies that are being done, like RCTs. Are you familiar with the details of them? Like, are they more with like just psilocybin as a therapy, or is it like psilocybin with psychotherapy? And the reason why I ask is just like, I guess, any like psychotherapy nowadays, it's so hard to even obtain, and if it is available as private pay, and so like a lot of our patient population, people access it. So like, it's great if it shows like good evidence, but like, can we actually achieve that with our patients? So I'm wondering what research is done.
So I'll just repeat that. So what kind of research is emerging, if you know that, are RCTs and access points for psilocybins, as many of it might be privately accessible right now?
Yeah, there's a number of different studies. Most of them are using psychedelic assisted psychotherapy, not just the psychedelic on its own. That being said, I think, as we move forward and if more and more literature and evidence comes out to support these therapies, I'm hopeful that if we continue to see positive results, we can hopefully get these more accessible to the public and for the people that, might need them the most, right? Because some of the folks that we work with, of course, are from lower socioeconomic status and so on. And so it's important for us to make sure that these treatments are accessible for people that wouldn't otherwise be able to afford it through private pay.
Okay, it looks like we're wrapping up here. No more questions from the online audience as well. So thank you again so much, Turner. And good luck for your rest of your fellowship.
Thanks, Mona.